Well, thank you all for this great conversation. It's fabulous. We have brand new approval to talk about here today. So before we wrap up, let's each go down the table here and maybe just give us one take-home message, that kind of struck you from our conversation that you just wanted to reiterate. Maybe start with you there, Ruth.
I think it's incredibly exciting to have a new regimen for triple-negative breast cancer, even though it's 40% of the population. I think that's just amazing. Hopefully we'll see more data with that going down over the next year or so. I also think that the whole liquid biopsy platform is really exciting in terms of tailoring treatment going forward.
Yeah, so I think one of the take-home points is just what we talked about in terms of the Catherine data. I think when that study was reported in the New England Journal, there were also, it's clear that this is a new regulatory path forward. So we have all of these exciting new agents that are coming down the pike in various diseases, in HER2-positive disease, antibody-drug conjugates, and triple-negative breast cancer. And it's clear that for those patients with residual disease, that this one may give benefit, but also is a good regulatory platform for bringing new drugs into clinic.
Yeah, that's such a good point. And yeah, that's what I wanted to also emphasize is I have some patients now who had surgery up front for HER2-positive disease, had multiple positive nodes, have had their TCHP, including in the adjuvant setting, and I would like to very much give them TDM1, and I'm doing peer-to-peers to try to get that, but it's sometimes challenging to get that in the adjuvant setting. So I think just the onus, as you said, Beth, it's really become almost a responsibility now to make sure that these patients have the opportunity to get preoperative therapy, so we can see if they're a PAF CR or not, and then give them the TDM1. I think that's such an important kind of new approach that we really have to do.
So, well, you have to say something different. So we'll focus on something else. So, to me, CDK4/6 inhibitors, it's great that we have the immune checkpoint inhibitor, but the majority of patients we see in the adjuvant, neoadjuvant, and metastatic setting have hormone receptor-positive breast cancer, HER2 negative. And we have these really well-tolerated drugs, 3 of them that are incredible. And I have a patient who relapsed at 3 years on tamoxifen, a young woman, node-positive disease, already in menopause, went on Paloma-2, and she's still on it at almost 6 years, 5.5 years. So, we're really changing the lives of our patients in a huge way. And this is a big population of patients, and that's really exciting. And so what I'm looking for is, what's incredible to me is we've already fully accrued 3 trials, 2 large adjuvant trials in high-risk patients and 1 post-neoadjuvant trial. And there's yet another trial which is now actively accruing with another CDK4/6 inhibitor. So, I'm hopeful that we'll have adjuvant data in the not-too-distant future.
Yeah, so cool. Beth.
Yeah, so it's hard when you go last to focus on something new.
But you're the surgeon.
Well, it's even harder when you're the surgeon and somebody's already taken neoadjuvant as the answer. So, clearly I'm enthusiastic about increasing awareness in the surgical community about the importance of using the neoadjuvant platform to inform subsequent therapy. But as all of you know, one of my passions, of course, has been immunotherapy, and so this is really a really exciting time, and I look forward to the data we've been discussing that we anticipate will read out in the coming year, but also what is now the challenge of trying to figure out how best to incorporate immunotherapeutic strategies into our standard practices with our patients.
Incredible progress in all of the time that we've had to practice. You know what I mean? None of us can retire because we're having too much fun. So, right, so love it. So, well, thank you so much for your contributions. It's really been fun talking to you all. On behalf of our panel, we thank you for joining us. We hope you found this OncLive Peer Exchange to be useful and informative for your practice. Thank you.